So before we get started, I would like to acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So we're still looking forward to people coming in person. It's always nice to see live faces. So just want to thank the people that are in the room and of course everyone that's tuned in virtually. I'm delighted to introduce a couple of relative visiting speakers to our grand rounds today. Both individuals work at the Royal ALEC, but of course are members of our department. So I'll start off with Dr. Naheed Rajabali. Dr. Rajabali was appointed as a clinical lecturer by the University of Alberta. He received his training in internal medicine and geriatric medicine here. He primarily works at the Royal ALEC on the acute inpatient ward and consult and geriatric emergency medicine consult service. He delivered care at the Parkinson's disease and movement disorders program at the K Clinic in collaboration with neurology from 2017 to 2022. He's particularly interested in devising approaches to tailoring care across various disease settings, particularly in the peri-op setting, where his research focus is on, and he also enjoys teaching. Dr. Keysun Ranjbar is a staff cardiologist at the CK Hui Heart Center and Sturgeon Hospital. He's assistant clinical professor in the Division of Cardiology in our department. He has fellowships in interventional cardiology and also heart failure from the U of A and holds American Board of Echocardiography and Level 2 certification for cardiac CT from Houston, Texas. In clinical practice, Dr. Ranjbar has special interests in managing patients with HOCM and syncope. Being a student pilot, he's also interested in aviation cardiology, and maybe he'll tell us about how those piloting lessons are coming along in his talk as well. So I'll hand it over to you. Thanks.
Thank you very much, Dr. Keysun. It's great pleasure to be here. For the sake of time, I'm just going to start and run quickly because definitely the second part of the presentation, Dr. Rajabali, is the very amazing and interesting field, and it's also new to me, practicing cardiology for about 25 years. So let's start here. Our disclosure. This is Dr. Rajabali's disclosure. This is mine. So no financial disclosure. So the objective is just to understand the complexity of the heart failure and also the modern approach to the heart failure, its definition, diagnosis, and management. And of course, to dig into more challenging space in this already complex situation and talk about these tailored medicine and how this will be changed in a specific or special group, particularly in the elderly. So why the heart failure is challenging? I have to admit that from the get-go, from the diagnosis definition, the heart failure becomes very challenging. This is the Cardiology Bible, Brownwald 2022 edition. When I was a cardiology resident, I was reading the basically studying based on the Brownwald 1998, and the definition of the heart failure was quite straightforward, more pathophysiologic basis. So when I did read this sort of paragraph, I got disappointed. I said, like, am I getting old? How come I don't understand what's going on? So I was kind of quite disappointed. And then I come to this statement from Canadian Cardiovascular Society, and then I realized that obviously this type of definitions is quite complex for most of our colleagues, and they're already admitting that these textbook type of definition and diagnosis would not be very practical. And why it's like that? Obviously, because the heart failure is a clinical syndrome, and it's not just that. This syndrome coming, like from a different variety of etiologies and very heterogeneous type of pathophysiology. So unlike let's say, a disease entity such as hemochromatosis, that you have a gold standard for the diagnosis and some sort of findings that you can rely on, make your diagnosis. With the heart failure, when we go forward, I'll show you, it's not that straightforward to come to even to a diagnosis of the heart failure. So of course, the other challenging part of the heart failure, if you look at the statistics, now we're reaching to the epidemic proportion of the incidence and prevalence of the heart failure. So about 22 million people around the world, they are suffering from heart failure. So when it comes to the population-based studies and scales, I would not be surprised that in the next few years or few decades, we're going to have such a big problem to become pandemic of the heart failure. And I think we should be prepared since these type of entities and problems have a significant burden in our healthcare system. So just again, just a quick review of why the heart failure is challenging. As you can see, this is a chronic and progressive disease. And again, I'm not really talking about some few entities. They're quite reversible. Let's say Takotsubo or stress-induced cardiomyopathy, that during that period, patient becomes decompensated and having heart failure symptoms, but they fully recover. Again, put those aside. Usually, most type of heart failure patient that we're talking about, they are suffering from this chronic and progressive disease. And this is very interesting slide to compare the quality of care of these patients with chronic heart failure compared to some other common entities in medicine. For example, if somebody is suffering from a sudden cardiac death, they can have a quite reasonable whatever quality of life they have, and all of a sudden, of course, that's a death, that's an incident. Even in the cancer patient, if you look at that, so the functionality and their functional status remains reasonably stable till, again, they deteriorate quite quickly and then going to kind of to end of the life. Now you see the heart failure, you know, it's very similar to what you see in the frailty situation. So it's a chronic deteriorating and deconditioning status, and they are very similar, and that's why this topic of tailored medicine, particularly the frailty, becomes important in this group of patient and heart failure patient. So just again, a brief summary so far. So heart failure is associated with a very high mortality rate. About 50% of these people, they will die within the first 5 years after diagnosis. And if you just go to 1 year, it's going to be 1 in 4. And this is, of course, the data from 2016. So even in that cross section of time, although these numbers might be changing, so don't criticize me on the, for example, the mortality rate of the breast cancer. But even if at that cross section of time, as you can see, the heart failure is even deadlier than these very common cancer disease and cancer problems. So, and yet we think that the cancer is the scariest problem. And if you talk to the cardiologist, we always said the malignancy of the malignancies of the heart is not very common, but actually the heart failure is the cancer of the heart. If you look at the course of the disease. So let's see some local statistics. So even the Canadian Cardiovascular Society believes that this is quite a silent epidemic, and 100,000 new cases every year in Canada. We have patients with heart failure diagnosed with heart failure, and as I said, you know, it's quite significant burden. So about 50,000 of these patients, they become hospitalized every year, and this data is from 2016. And about 20% they have more than one hospitalization. So this is again based on all the low interest rate and inflation rate. But just imagine from 2013, about $500 million Canadian dollar we spending on patient with heart failure. So just imagine what would be that number even today. So what's the landscape of heart failure in Alberta? This is basically what I would like you to pay attention, because we need help from, you know, all other disciplines, particularly family medicine and internal medicine, because we need more help with this sort of huge burden in this entity. We need to get everybody possible involved. So you see that they are less than 40% of these patients, they will be managed jointly with primary healthcare and the specialist care, and that's not really good. And we know that the evidence supporting that having such a team approach would be very helpful and improves the outcome in patient with heart failure. And of course, not having access or using echocardiography as the common method of assessment of LV function is another issue that needs to be addressed even in Alberta. So as I said, I'm trying to just give you a quick insight of management of the patient with heart failure and its classification, and also then focus on this special group of elderly and frailty. And there are different reasons that why non-cardiologist physicians, they may not be involved in the management of heart failure. It really depends, sometimes the personal preference, sometimes, your practice setup is the way that, you don't want it to, or you're not really interested to see these type of chronic patient and resources. But of course, part of that could be not being comfortable or not quite familiar with the body of the evidence. So that's why we wanted to basically tap on that and then go forward. Unfortunately, we're supposed to have a live poll just to keep the audiences more involved. But unfortunately, this software that I use for a live poll doesn't run on the computer system at the here in the auditorium. So let's start with the diagnosis of heart failure. So I said the definition and diagnosis of heart failure is already a challenge. So if you look at any textbook in cardiology, these are the typical symptoms of heart failure, and these are very common or typical symptoms as signs of heart failure. But even if you look at those numbers, none of these are quite 100% sensitive or specific. So you cannot really use any or combination of these to completely exclude or rule in the diagnosis of heart failure. And if you look at this diagram, looks like this culture of being politically correct, is kind of getting widespread. So even despite going through all these complex steps and using different modalities, at the end, as you can see, nobody's going to come and say this is 100% heart failure diagnosis or this is not heart failure. It's likely or it's unlikely, and that's why heart failure is really a challenge, again, even at the level of diagnosis of the problem. So quick word on the BNP. BNP is very helpful. There's guidelines, there's evidence, and particularly the pro-BNP, which goes, of course, by age, but even the BNP or pro-BNP, they are not 100%. So if somebody comes with a more acute symptoms and then you don't see any significant BNP rise, you cannot necessarily exclude the heart failure. You still have to think about that in that proper clinical setting. And there are some entities that BNP may not be necessarily high, for example, in morbidly obese patient. And there are some people, they might have a little bit of higher BNP level to begin with, even if they don't have a heart failure, such as patient with the chronic kidney disease or patient with some history of SVT or supraventricular tachyarrhythmia. So they might have a little bit of higher BNP, but they are not necessarily having the heart failure. So keep that in your mind as well. And when it comes to classification of heart failure, I just wanted to give you an insight why we classifying the heart failure like this. Again, 25 years ago, when I was in the cardiology program, the classification was based on this very fancy pathophysiologic term: forward heart failure, backward heart failure, right-sided, left-sided, low output, high output. Now it's been changed, and this change is now based on how we manage these patients. So that's why hopefully you can see, but the classification is now based on the ejection fraction, and we have these now new 4 entities that what we call heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and HEF-IMPEF. This is a new entity, heart failure which is improved. So HEF-IMPEF. So in terms of the prevalence, kind of 50-50. You have this HFrEF or heart failure with reduced ejection fraction, means ejection fraction is less than 40%. And you can kind of put that HFmEF into the side of the HFpEF. They are either normal ejection fraction or low normal or mildly reduced. So they are 50-50. And starting with some case, again, unfortunately, I cannot do a live poll, but quickly going through this case is a 52-year-old guy coming with 4 weeks history of shortness of breath, really no significant medical history, admits that he's quite a drinker. This is a physical exam. Pay attention to his blood pressure, which seems to be fine, but just pay attention that it does have a very narrow pulse pressure. And heart rate is a little bit on the tachycardia side, and otherwise on exam JVP is not quite elevated. S4 is there. No significant ankle edema, and abdominal exam is unremarkable. These are the blood work, so you have a supportive or supporting BNP level. Chest X-ray is also supporting the mild cardiomegaly, ECG mild sinus tachycardia. So you have the advantage of having epicardium for this patient, and the ejection fraction is coming to 35%. So as I said, sorry about that, but the question is, what would be your next step if you're seeing this patient in your practice in terms of medical management? What you're going to start? So the question designed just going through using ACE inhibitors, using or ARBs, using spironolactone, using Lasix with upper low, and just wanted to again just to see what would be your approach. So we're gonna talk about that, but keeping in your mind, this is a second here just as an example that you have a 79-year-old guy, progressive shortness of breath, ejection fraction is 51%, so it's kind of falling in that group of HFpEF, and hypertension, typical case scenario for those people with the HFpEF, anemia, CKD, diabetes. He's on reasonable medication for his condition, obviously. His function class 3, obviously, blood pressure is fine, 2+ edema, JVP is elevated, sinus, ECG sinus with right bundle, and the BNP, which is also supportive, a little bit of worsening of renal function and potassium of 5. Again, the question was, what would do as a next step for this patient? Adding a little bit of Lasix, adding spironolactone, adding SGLT2 inhibitors, or switching the patient from ramipril to Entresto or ARNIs. So then here, and like I brought this question of what is the 4 pillars of guideline-directed medical therapy, which I show you in a different slide. So don't worry about that. So these are some few statements just from a great work of our world-class expert, Dr. Ezitkovich, and Dr. Michael Chan from Roy Alex. So they just putting this into action in Canadian guidelines for heart failure treatment. Now you see that there are a few things that I would like to highlight here. Number one, like the role of SGLT2 inhibitors, the ARNIs, and also very important is this to start all these treatment as soon as possible. Remembering what we're talking about, the heart failure is the cancer of the heart. It's very important, same thing like a cancer, not to delay the treatment, because as soon as they get hospitalized, then the time is ticking, okay, and then the mortality and everything is going to go in the wrong direction. So this is again the quickest slide showing the cumulative mortality and the benefit of all these treatments. So when you add that, you see you have a relative risk reduction of almost 73%, absolute risk reduction of 25% number to treat grade 4. So it's very important to stick into this, what we call the 4 pillars of the heart failure. And this is, of course, applying to patients with heart failure and reduced ejection fraction. So these are ARNIs, beta blocker, and MRA, and SGLT2 inhibitors. Same thing, there's a new medication supposed to be available in Canada, but I think it's on hold. This is, again, a great medication from our world-class scientist, Dr. Armstrong, and also Dr. Ezitkovich. So the Victoria study, and again, for some reason, it's still not available in Canada, at least in the market. But hopefully, this comes into action. So, what I would like you to see on this slide, visually, when we put such a slide or prepare such a slide, you're just focusing on that center. All these fancy stuff, medication, 4 pillars of the medication, like even some other modalities such as the CRT, defibrillator, some other advanced treatment. But look at that yellow color column, and that's what my colleague Dr. Rajabali is going to elaborate that, and that's very important, how to individualize all these medication and treatment, in the special group and in each individual patient. So again, I don't want to go through all these details. I'm pretty sure that the data is there, the evidence is quite strong, and of course, more to come. But this is a good slide to show you that for a long time, the body of evidence was around heart failure with reduced ejection fraction. Now we have lots of studies coming to support that there are medications and they are effective with good evidence that we can use for the patient with HFpEF and HFMRF, or mildly reduced ejection fraction. So also a recent statement from FDA that we can even use the ARNIs even in a patient with HFpEF. So there's some supportive evidence. Again, the evidence is not that strong, but it's a trend. So few words on the safety of these SGLT2 inhibitors, which is probably the new member of this treatment for a heart failure patient. Always, of course, the patient, they may ask if these medications are for diabetic patients and they reduce the blood sugar. So am I safe, as a non-diabetic to use that? You see that the study is showing that obviously the risk of hypoglycemic events is not different between placebo and patient taking SGLT2 inhibitors. So this is again the importance of starting the treatment as soon as possible and try to optimize in few months. And if we don't do that, again, still the mortality and the event rate would be high. And there are different strategies. So you can do it very aggressive within 6 months. You can be more practical, or maybe like me, very conservative, and then you achieve this to 12 months. But again, the idea is just to start as soon as you diagnose the patient with heart failure. Don't waste the time. When we have to refer these patients to higher level of care, usually to a specialized heart failure clinic, we have a very great program here at the U of A and also at the Royal Alexandra Hospital. So if your patients are high risk, such as a recent discharge from hospital, high New York Heart Association, or if they need a higher level of care, such as device implantation or even advanced treatment. So this is a good diagram showing that when the patient become cool and dry or cool and wet, these are usually high-risk patients. We like the patient to, of course, to be on that pink corner, but even the yellow can be managed most of the time with good outcome. But when they become cool, or particularly cool and wet, those are the time that those patients need higher level of care, even ICU or CVICU type of admission. So why we are obsessed about this hospitalization? Under that magnifying lens, you can see that with the first hospitalization, the survival would be 2.4 years. Means this patient may not see the next 3 years with the first hospitalization. If your patient having, let's say, 4 hospitalization till up to this moment, it means they're not going to see the next Christmas. There's a very possible that they may not see the next Christmas or this upcoming Christmas actually. So that's why the hospitalization is important. Of course, when it comes to policymakers and the healthcare costs, you see the heart failure and COPD together, they're quite significant. They have a quite significant burden, in the cost of the healthcare and length of a stay in the hospital together. And even heart failure is more than COPD as a single entity. So some practical tip on the GDMT, and then I will pass the microphone to Dr. Rajabali. So if you wanted to start with the beta blocker, so make sure your patient is already on the dry side. So it's not a bad idea. Remember the first case, just give a little of Lasix, just make sure that the patient is drier or dry, and then you like implement the beta blocker, particularly if you're doing as an outpatient setting. About the choice of the beta blocker, again, if the heart rate is a big issue, you may choose a bisoprolol. If the blood pressure is soft, same thing. If you have a good blood pressure support, then you may just go directly with the carvedilol, which they have the strongest evidence in that regard. When you wanted to start the ARNIs and those agents, because there is a chance of hypotension or pre-renal AKI, compared to the beta blockers, you let them to be a little bit wet. So you don't want it to overdiagnose this patient, let them to be a little bit wet, and then you start or switch over to these agents. Hyperkalemia is always a challenge. Dr. Rajabali is probably going to show you in his slides. And if there is any question, let me know. Otherwise, for the sake of time, I just pass it to Dr. Rajabali.
After having heard everything that Dr. Ranjbar has said, is there compelling evidence for GDMPs for everyone with heart failure, ICDs for everyone with an indication, LVADs for everyone with advanced heart failure? Yes, no, I'm not sure. Okay. Some of the thought behind this is just to remember that RCTs versus real world management and outcomes are not often congruent. There are number needed to treat, and even the best number needed to treat suggests that not all patients will be getting the benefit, and if they do, it'll be variable. Studies are often not powered to stratify for those who are frail or who have diminished reserves, and frail patients, as even Dr. Rajabali mentioned, have typically poor 6-month, 1-year prognosis. For quality of life outcomes, there's a tendency to have potential selection bias or volunteer bias in favor of those who are already relatively fit, and prevalence and population-based decision-making isn't reflective of tailored care. In reality, what you have is a heterogeneous pattern in the demographic with varying reserves as well. So heterogeneous disease pattern, heterogeneous reserve pattern. So, but first, we already know our cardiologists that are cool, including the electrophysiologists. But what do we know about geriatricians? Just as an example, my scope of practice, we see a variety of diseases in our acute setting, chronic setting. We appreciate functional quality of life, and we have additional training in things like behavioral neurology, movement disorders, psychiatry, rehabilitation, and quote unquote geriatric syndromes, which is a term that I'm not in favor of, but that's for another time. And then beyond functional quality of life, we also appreciate that there's a dignity behind an individual. So additional training in palliative care, in the management of very frail patients, and in capacity assessments and so on. There's an emerging concept in medicine, and that is of tailoring outcomes and tailoring management based on reserves and stressors. So what does that mean conceptually? Well, if I were to ask you, if you were to have things walking on ice, would the ice break, right? Well, you'd say, well, of course, it depends on the heaviness of whatever's walking on it. So a big bear versus a little bear, and which we call stressors. So that's a stressor of the disease, stressor of the treatment, which is a double-edged sword, or the reserves, the thickness of the ice. Well, we have stressors, we have lots of things where we can quantify, but we have a tendency to use age as a marker or surrogate for reserves. This is just an example of how we can use variability in disease severity to look at stressors in a disease. So neurocard association, for example. And then that can be translated into looking at risks for outcomes based on that severity. So things like the MAGIC score and Seattle Heart Failure score can be helpful, but they don't quite capture reserves. They sometimes underestimate risk in HFpEF, and they focus on mortality, although even rehospitalization. But that's only one part of the equation. So what about age in terms of appreciating reserves? Well, this number 65, it's somewhat arbitrary. It's kind of what I call a political number. So it came about in the 1930s when life expectancy was increasing due to advances in public health, and there was enormous public pressure for things like pensions and health insurance. And so under that pressure, the government asked scientists and physicians at the time to come up with an age. Well, they suggested we need to look for a biologic age, but it's going to take time to kind of figure that out. Well, against public pressure, they came up with the number 65. This is the government. And that number has stuck since then. And we incorporate that into medicine as well. In reality, when you look at the chronic disease demographic, what you find are individuals that are fit and frail across the numeric age spectrum. So people say, what do you do for a 70-year-old with heart failure or a 70-year-old with Parkinson's? The answer is, it depends. It depends on their reserves. So we'll talk about that. So this is just another way to quantify that. So if you look at sort of the godfather ways of assessing reserves, so the Freed and the frailty index, across a group of Canadians, 18 and over, what you find is that there are fit and frail patients across the chronological age spectrum. So does it make sense to draw an arbitrary line at 65 and say we're going to treat them all homogeneously and have rules for them and then rules for those under there? Or does it make sense to treat people on their true age, on their true reserves? The same is true specifically for even the heart failure demographic. You find individuals who are frail, pre-frail, and not frail or fit across the chronological age. So does it make sense to draw an arbitrary line anywhere in the numeric age spectrum and have differing set of rules? Okay. So the world's sort of coming around to this notion. And so the term old age now has been withdrawn from the ICD-11. So even some of our geriatricians sometimes I think are guilty of using this term older age. We need to move away from it because there's an understanding now that it's heterogeneous and that chronological age is of limited use for diagnosis, prognostication, and treatment guidance, and of limited use in terms of healthy aging, promoting healthy aging and social care. So when we talk about reserves, what do we mean? Well, I wish I can get into more of this. It's really fun stuff, but that's for another time. But conceptually, what you're saying is for an individual in front of you, if you were to hit them with heart failure or surgery, I don't want to hit anybody with anything, but if they were to be hit with that, okay, what would they be able to come out of it with resilience? Would they still be functional at the end? And so conceptually, if you look at extreme cases of those that are fit, so if you can say these individuals are the same numeric age, 70, let's say, you would probably be right in saying that these guys would come out of their stressor better than the person at the bottom here. And there's different ways of now looking at it scientifically and different ways of measuring it. And it's not so obvious in the real world when there's a spectrum. So, like I said, there are many tools. It's beyond the scope of this talk. But we did publish something in 2016 that spoke to a little bit of it. So you can always refer to this. And now there's lots of evidence since then as well for the tools you can use. So let's just look at some examples where it's incorporated in heart failure. When heart failure alone in this study, they used a multitude of tools. They used the clinical frailty index, the Edmonton frailty scale that Dr. Rolson has derived, Freed, and so on. And what they found, and I tend to use a clinical frailty scale, for example, but it has a good correlation coefficient with some of the more robust tools. If you're worried about time, it takes a minute to do. It takes a minute to be able to determine someone's reserves. And it correlates well. There's good interratal reliability, and it's got good sensitivity and specificity compared to some of the more robust ones. And in terms of predictability for outcomes, if you use this tool in a stratified way, it tells you that those who are more frail, middle frail, less frail have respective changes in their 2-year survival, rehospitalization, and other quality of life outcomes. So those are great tools to use. And they do better have better predictability for outcomes than just using age or other markers. So now what? So we have tools, you can incorporate them. I guess the first step I would say is take a tool and start incorporating it. I think there's a lot of discussion out there. There's a lot of data. It's about time you pick up a tool and just use it for yourself. It can help in early diagnosis, set realistic outcomes, target resource allocation, and reduction in burdens of healthcare. And I'll talk about this. So tailoring on the basis of heart failure profile, Keysun Ranjbar spoke to it quite nicely. But then you can also tailor based on comorbidity profile and reserve profile. I'd like to add one thing. I was talking to Justin Ezekowitz just before this, and he mentioned, tell the people that do not use frailty as a crutch for clinical inertia. So you have to strive to still manage people's quality of life. It shouldn't be something where you just write them off. It was a good line, so I have to give him credit. Okay, so tailoring based on the basis of patient comorbidity profile. You have your 4 foundational GDMT medications. You can have people with CKD, no CKD, bradycardia, not bradycardia, hypotension, AFib, no AFib, and different combinations of it. And you can tailor care based on that. I'll choose hypotension, symptomatic hypotension, and orthostasis. These guys have a high risk of falls, high risk of reduced activities because they're fear of falling, and low functioning. And potential contributing factors are sarcopenia, non-compliant vessels, perhaps dysautonomia, FF Parkinson's, BP lowering meds, common ones, and side effects of those like levodopa, other things to think about, PEs and whatnot. And the question then becomes, do you focus on GDMTs duration of life features, or do you focus on functional quality of life when there is a conflict? The answer is, I would say, focus on functional quality of life. And so you can do a lot of things. You can start reducing some of these medications and keep the focus on reducing symptomatic orthostatic hypotension. I had a conundrum like this when I was at the Parkinson's clinic, where I was concerned about reducing levodopa, increasing motor symptoms and further falls. And I got in touch with, I think Bibiana Kujic and I were co-managing this patient, and we agreed to reduce the ARNI, accept the increase in afterload, and just monitor the patient. And she did fine. So you can connect with each other. Other conundrums that you might see on inpatients, heart failure and steroid use. So for COPD, for example, does the patient really need that steroid if they have minimal to no work of breathing, minimally hypoxic? Because adding a steroid may precipitate or exacerbate heart failure by way of fluid retention. And if a steroid is required, pay careful attention. Are you precipitating an underlying heart failure? When it's there with sepsis, avoid knee-jerk fluid resuscitations or just maintaining fluid indefinitely. Remember, IV antibiotics have salt content. What we suggest and what the evidence is trying to suggest is cautious bolus of fluid resuscitation. If required, monitor for congestion. And then once things are settled out, initiate the diuretic again. And then for pancreatitis, we see common conundrums in cirrhosis and heart failure and these other entities. It's a fine balance because concomitant pulmonary congestion results in poorer outcomes. So you should have judicious use of fluids to potentially avoid severe or necrotizing pancreatitis, but then also you have to accept some degree of pulmonary congestion as well. And then resuming the diuretic once things have settled. So now, tailoring based on cognitive reserves and physiologic reserves, so frailty. These ladies are like 90s and they still play basketball. It's fascinating, but okay. So I'll give you a case, for example, 75-year-old lady with anxiety that's been stable for decades, no previous cardiac history, presented to the ER with a 1-week history of anxiety plus, insomnia, some episodic bouts of dyspnea, no peripheral edema, no other signs and symptoms of infection. Chest X-ray shows cardiomegaly, a bit of opacity in the right claustrophrenic angle, pro-BNP is elevated, no AKI, and inflammatory markers are normal. And she had a previous history of diarrhea a month ago, which is resolved. So does this patient have this? Okay, so it's not black and white like Keysun said, but is this patient likely to be in heart failure? Yes, no, I need more information. Okay, we'll look at the answer in a bit here, but she was started on antibiotics for pneumonia, sent home, and then there's now patient cardiology referral and put on echo. So with the advent of the new universal definition of heart failure, which is accepted by everybody, the Americans, the Canadians, India, Australia, it really makes it simple. So having signs and symptoms of heart failure or some kind of structural deficit that you know of, corroborated by at least one of the following, which is an elevated BNP, or objective evidence of heart failure or congestion on a chest X-ray. So with this definition, you would say this lady is likely to be in heart failure. So 2 days later, she returns with sustained symptoms, some GI discomfort, reduced appetite, and was given an antiemetic, sent home. Comes back again 3 days later, shortness of breath, orthopnea, with some increased lung markings and an elevated BNP, started on Lasix 20, sent home. Comes back again to our emerge, similar symptoms now with a bit of orthopnea. The anxiety, insomnia were quite prominent, so she was put on J-side psychiatry. But the emerged up was still concerned enough about her well-being, consulted us to kind of manage this whole package of whatever she was presenting with. And when we just looked at her stuff, it was quite, well, at least we thought, apparent that she wasn't discompensated heart failure, despite no hypoxia or peripheral edema. We put her on Lasix right away. She had improvement in her symptoms right away. And then her GI symptoms, anxiety, no AKI with this. Had a short stay. Her echo a couple of days showed an EF of 30-35%. We started her on GDMT, partial GDMT, ruled out PE, and consulted cardiology, further optimization and follow-up. And she did well. So key things here, heart failure diagnosis, like Keysun mentioned, if you rely simply on your classical, typical signs and symptoms that we've all learned through med school residency and in our careers, there's a chance of misdiagnosis in 16 to 65% depending on the setting. And in the ER alone, it's about 1/3 of misdiagnosis or underdiagnosis. And in those who are elderly, which there was a big prevalence of those who are frail, there's about a 50% miss possibility of missing heart failure. And so the key here is patients can present with both typical and atypical. Atypical can be more prominent, and typical can be subtle. but do rely on the new criteria. Okay, and this is a bit more of what Dr. Ranjbar already mentioned, but just some atypical things can be loss of appetite and bloated. Sometimes geriatrics is consulted for this, and they're in heart failure because they have gut edema, or confusion if they have low cognitive reserves. This is what they can present with, and you may miss the subtle signs of orthopnea. There's something interesting called bendopnea. You can kind of read about this. It sort of came out in 2014. And then the absence of peripheral edema does not mean that they are dry or euvolemic. You may be very well missing heart failure. Patients talk very well about the pro-BNP. I encourage you to use it in your clinical practice for various reasons. He also touched on when it can be high or low. Right. The chest X-ray can be a helpful tool when it does something, but in 20 to 30 patients admitted from ED with diagnosed heart failure, there is no pulmonary congestion or on their X-ray. So if somebody's got a clear chest X-ray with symptoms and elevated BNP, of course you should think about a PE, but then also think that this could be heart failure. And if they have a high BNP with pneumonia, think, is there a superimposed phenomenon? Don't just focus on the pneumonia, hit them with salty antibiotics, and then you have to think that could there be a concomitant issue? And now with focus lung, we potentially could increase the sensitivity of these findings. So this is another concept too. With CCS guidelines, patient may be in heart failure without a history of volume overload. So the absence of peripheral edema does not mean that you're euvolemic or hypovolemic on that basis. Some people say, well, they have dry mouth. That's not reflective of fluid status. And an infection does not necessarily mean someone's dehydrated. It may be compensating heart failure. Like the case we saw, avoid hedging if you can, because half measures don't help anybody. Commit, either you properly diurese or resuscitate. It will give you direction. Even if you're wrong, you can correct right away. With our atypical patients, we don't have the classic findings. We have to commit. This is how we end up with a good diagnosis and then manage. So this is a good tool, CCS guidelines by Izikowicz. It's good for diagnosing heart failure. I use it all the time when I'm not sure. It's very helpful, but there's caveats to it, of course, like we mentioned. You can go over that when you get a chance. So management based on reserve profile. There's emerging evidence. Part of it's extrapolated from other evidence that's not necessarily cardiac or heart failure, and in my own clinical experience and so on. So this is putting it all together. Those who are very fit or managing well, regardless of their age, do not withhold treatment. There's a tendency to be suboptimal in management of those who are chronological order. I call it hypopharmacy, but be mindful of that. And those with mild acute heart failure may be okay being managed as an outpatient setting or virtual hospital, or even as you as a clinician, no problem. Goals of care R1 to R2 is okay. There's emerging evidence that those who are fit, even regardless of age, do a little bit better than those who are frail. Of course, for things like transplants and goals of care, higher numeric age may have an ethical perspective before when having that discussion. And then avoid a good enough attitude. Don't say, well, you're good enough for 80. No, we can do better. So what's doing better? Mind, body, spirit, all the hokey stuff, or not hokey, but at least things that certainly I used to roll my eyes at in medical school, but it's starting to be more and more, as a geriatrician now, you realize it's actually the crux of what we do. You have to promote these things, and even within ourselves, you can't expect others to do something if you're not doing it yourself. So we all have to be in this together. Walking merely isn't sufficient, and these things don't just help cardiac issues. It's helpful all around, everywhere. So let's look at specific things. So if somebody is frail, even a mild presentation may warrant an admission because their reserves are low. Okay, so what do we do with diuretics? So this is the warm and wet people that I'm talking about here. In the hemodynamic boxes that Dr. Ranjbar showed us. Typically, I try to get fluid out ASAP, especially in those who are frail or have dementia, because you want to clear that delirium or reduce the onset of it. You want to get early mobilization really fast, and you want to have less deconditioning. It reduces length of stay. And at times you've had to take transfers from medicine and be a bit more aggressive in their management. And a few weeks ago, we had a lady who needed to put 120 milligrams IV BID of Lasix with metolazone, acetazolamide, because she had contractional ankylosing. But imagine, and it took her 8 days to recover with the taper, may have overshot a bit, but that's fine. We sorted that out. But imagine if we just kept her on 60. How long would that have taken, right? So you don't have to get that extreme with everybody, but my advice is be a bit more assertive than you normally would with these kinds of patients. And of course, monitor for all the side effects. Peripheral edema, aim for proper euvolemia. So typically what I find on consults, but anywhere else, people may just remove enough fluid so you're not hypoxic anymore and then send them home. But remember, patients with edema bilaterally, it's like having, especially if they're frail, it's like having two toddlers hang off of you. If you have any kids, now imagine being frail and walking around with that much fluid. It's so what I say is spend an extra day or two, may compromise your ELOS by a day or two, but that's okay. It will do better for that patient. Okay. AKI often is type 1 cardiorenal, sometimes it's type 5 from sepsis. Sometimes it's a leading marker for iatrogenic heart failure. So patients may have atypical symptoms. Let's say they have sepsis, have been on IV antibiotics for a little while, and no one's really paying attention. They have atypical symptoms, but then you start seeing them being in AKI while they're being hydrated. It's likely a leading marker for heart failure, so keep an eye. And then if renal failure gets worse, question, is this obstructive uropathy? Do they need PVRs or Foley if they have prostate issues or bladder issues? If you have paradoxical worsening of AKI in heart failure, it's associated with poor prognosis. So if they're fit, get a nephrology consult, maybe they need hemodialysis. But if they're frail, or at least moderately frail and onwards, start looking into palliation and veer towards keeping their lungs dry. It's not fun living like fish out of water. And what I would say is avoid middle of the road, because we see what happens sometimes. Patients are sent home just a little wet to try to save their kidneys, but then they're still in like a little bit of pulmonary congestion. They keep coming back and forth. You have to have those sensitive discussions of goals of care. Choose a direction. Okay, diet. Patients may have low appetite and nutrition due to gut edema. So again, assertive diuresis, initial sodium restriction diets, okay. But what I advise is this: see what they can sustain at home, because depending on some people's cultures, they're East Asian or China, Central Asians, or if they're frail and have dementia, they may not be able to sustain the pristine diet that we may encourage them to. So you try when you can, but if it's not possible, tailor your diuretic to what they can sustain. Get a dietitian to confirm. Because what you might do is you might end up being suboptimal in your diuretic regimen in hospital. They go home, they eat what they want, and they come back. So you need to kind of fit into their reality. Okay, and those who are non-adherent to their heart medications and coming in with decompensated heart failure, think, do they have dementia or are they depressed? And refer to the right people to try to help you answer that question. They may need blister packing at the very least. So this is another conundrum: heart failure versus progressive frailty. How do you determine when someone shows up to you? Is this progressive New York Heart 1? By the way, no, this was not my 4-year-old writing, sadly. But or is this progression of frailty? How do you determine that? Well, one is chronicity. Worsening New York Heart is usually a bit more subacute in nature versus frailty, which is more progressive. Also, those who are fit with worsening New York Heart will not have issues of sarcopenia, which is more chronic. So you shouldn't need one-person assistance to get into something. You shouldn't be having difficulty using a walker or a cane. That's all signs of progressive frailty. It's bigger than that, but again, it's beyond the scope, but this is something to keep in mind as well. And then sweet spots for resource allocation. You know, we talk about the burden on the healthcare system. Well, stratifying people based on their reserves can help with this. So in this one eloquent study, when they stratified people based on their level of fitness and frailty or reserves and decided to randomize them into intensive care, post-heart failure as an outpatient, with specialists, patient, family educators, plus follow-up versus usual care, which is just their PCP, internist, or cardiologist, what they found was that benefits were not the same across the spectrum. There was more benefit for outcomes in those who were mild to moderately frail, no benefits in those who were fit, and some marginal benefits in those who were severely frail. And when it came to cost savings, there was more abundant cost savings in those who were mild to moderately frail compared to those who were severely frail, where there's marginal benefit, compared to a loss of any cost savings in those who were fit. So we can tailor care and then tailor resources for good outcomes. Okay, let's see here. Something's stuck. Oh, here we go. All right. Other things, and those who are vulnerable to frail and onwards, the cumulative evidence suggests that maybe ICDs and LVADs may not be beneficial, may actually be more harmful. Our 2 goals of care would likely be more harmful. And look for things that may be causing them to slow down. It's not just old age. They have Parkinson's, they have malignancies, they have MSK issues, and so on. This is just more evidence for LVADs, that if you break it down into fitness and frailty, you have better outcomes in those that are fit than those who are frail. So it can be a good tool for decision making. Okay, even when it comes to things like physiotherapy, rehabilitation, there's rehab HF demonstrated that early aggressive rehabilitation can be helpful. In this study, they broke it down even more and they compared it across fitness and frailty spectrums. And what they found was that those who are, equivalents of sort of mild to moderate frailty did better in their improvements with rehabilitation than those that were pre-frail. And this supports more encouraging evidence of sweet spots in where to apply your rehabilitation practices. Okay, so and those are moderately frail and onwards. These are the guys who need help with, VADLs and so on. What do you do for that? So what I would say is this, again, don't withhold treatment simply because of age, but weigh it a little more carefully. A lot of deaths in this demographic is due to non-cardiovascular, non-heart failure. So set a relatively high threshold because they come with their own vulnerabilities, right? They come with their own comorbidities. So don't withhold, but set a bit of a higher threshold. When you start them on it, follow them a little more carefully and leave a lower threshold to reduce what you need to. And the focus with these guys becomes symptom management and management of or preservation of residual functional quality of life rather than duration of life goals. And when you have goals of care discussions, I recommend with those who are 6 or more, you be honest with them and say, R1 to R3 may do more harm than good, M1's probably better. In those who are severely frail and on, C1 goals of care, and then less likely benefits for things like ICD, LVADs, and so on, limited rehabilitation, potential sustainability. And these guys, discuss supportive living. There's also some hope, which is again beyond the scope of this talk, of disease modifiers that may be maybe hopefully arriving in the near future. Okay, so again, I come back to this question. Is there compelling evidence for GDMT for everyone with heart failure, ICD for everyone with an indication, and LVADs for everyone with heart failure? Is the answer yes, everyone with an indication should receive all of the above, or no, studies have limitations and may not capture the granularity in the population being studied? See, I'm not sure. This one we can all have our opinions about, but it all opens up the way for more dialogue and more thought. Yeah. Good. Any questions? Anybody? So this is the end. Yeah, the summary. I'll just leave it up there.
Thank you to both of you for really, I think a very practical, actually stay up here, a very practical and, sort of helping to identify sort of that art of medicine as opposed to the, just applying the evidence. Now, I know that Justin would be really upset if I didn't mention the heart failure bundle. So now, as of last weekend, all sites have gone live with Connect Care in the Edmonton zone. And so, of course, we have the heart failure bundle. And again, just encouraging people to use that evidence-based approach. And I think built in there is also the frailty scale, if I'm not mistaken. At least I've had easy access to it. So just again, to reiterate that. Just a couple of questions online that I'll go to. First of all, Vijay asked about POCUS. And especially in the group that you presented, or the type of patient you presented where, it's kind of uncertain which way their x-ray looks not too bad and so on. What can you comment on the role of POCUS in heart failure? And I'll trade you places here, or, do you have any experience with that?
A little bit. So I did take a POCUS thing about a year ago and I was using it and then it didn't practice. So I've kind of been a bit much. But I did, and you look for those B lines and so on. So it does give you a bit more edge when you're not sure, especially if your chest X-ray is not very good. I would actually defer that to somebody who probably uses echoes more, or even the ED docs out there who probably use it more to get their perspective on it. But certainly emerging evidence suggests that it can be helpful. It is a little more sensitive in detecting it when chest X-rays don't.
Yeah, I think just to add the comment, as we know, if we talk to the radiologists, when you're talking about the chest X-ray versus something like a POCUS, an echocardiogram, and ultrasound, with the chest X-ray we have a therapeutic and we have a diagnostic gap. So sometimes even if the patient comes with a flash pulmonary edema, it may take time to be reflected on the chest X-ray. So that, as far as I remember, from the radiology textbooks, sometimes it may take up to 12 hours to diagnose. So we have a diagnostic gap and we have a therapeutic gap. So you treat the patient is dry perfectly fine, and still do a follow-up chest X-ray, it might be still congested. And then it may just basically trigger you to continue with the diuretics and basically over-diurese the patient. So I think that the role of the echocardiogram, particularly if it becomes more standardized, maybe, in terms of the the learning curve and all those stuff would be very helpful. And I don't have really that much experience myself, like using the POCUS, but definitely with something compared to the chest X-ray that that there might be a gap, diagnostic and therapeutic gap, and like it might be helpful to be used in acute setting, particularly in the front line in emergency department, to quickly get that direction. And as Dr. Rajabali said, pick up a direction and then commit yourself to that. And then again, if something is wrong or something is changing, you can always change your diagnosis and change your pathway. But don't just kind of play, like in between, like a little bit of this, a little bit of that. That's definitely is not helpful.
Just commit.
Exactly.
I'll just comment that BJ mentioned that he had a 94-year-old patient recently where the patient was sort of ready to dismiss herself, and they maximized her treatment with 120 of Lasix and some metolazone, and she's doing much better. So, we see these cases very commonly on the wards, of course. So I have a little bit of a bit of a challenge in our current, I don't know how to face, in our current environment of hallway medicine, right? That those of us that do inpatients are experiencing. You talked about some of the benefits of sort of watching the patient for an extra day, maximizing maybe IV treatment and things like that. And, we balance that with our current healthcare crisis that we're in, because as far as I'm concerned, that's what it is. When you're treating patients in the hallways, it is a crisis. And so, how do you balance that? I mean, I could say pretty much most of my patients that I end up discharging, I really, in a lot of circumstances, I wouldn't say all of them, but in a lot of circumstances could benefit from another 12, 24-hour stay to maximize things. I mean, there are others where I think sending them home earlier is ultimately better for them. But how do you balance that act, right, in between our current reality and some of the information you presented there?
I think there's a lot of things that we did challenge even for us, to be honest, and we know it's every day. Right?
You want to just, I don't know if they can hear you.
They can hear, but
Yeah.
not see.
Sure, yeah. Well, the challenge there, it's even for us, and of course on inpatients, you have your transition coordinators, and on rounds, everyone's, discharge, because of pressures, right? So it's not easy, but I think there's some factors we look at. Again, reserve, how much reserve they have, how much they don't, how much support they have at home, how much they don't, right? Have they had recurrent, how often are there recurrent hospitalizations or not? So those kinds of factors help. And even we try to compare to before, also have them out the door sooner than later. But we look at those other factors to help as well. And it's never a good feeling either way, to be honest, sometimes. So
yeah, that's a great point. I think we have to keep that in our mind. Even if our goal is just to, let's say, offload the hospital, for the sake of a better quality of practicing, not to have a hallway type of patient. But if, as you mentioned, if you discharge them a little bit earlier, so they can stay a little bit longer. So basically, what happens, they probably going to come back, and then that's going to have the same vicious cycle. And I think that's why in my talk, I focused on using the other resources in the community. We have now kind of intermediate, heart function program. So we have in our clinic, in Edmonton Cardiology Consultants, we have this setup that to see these patients more often when they kind of coming out of hospital, and then to follow with them closely. Same thing with the family doctors. I know that there's already some shortage of family doctors just to do the sort of the whole sort of in their whole scope of practice, but still the heart failure, as I showed, it's a big issue, and just with the number of the cardiologists, for example, we cannot really handle that. And these patients, they need some sort of closer follow-up when they go to the community. Otherwise, if you're right, if you send them maybe a little bit earlier, for the sake of, to deal with the crisis in the hospital, basically it might be counterintuitive, and then they may come back, with the same problem and rehospitalization, which we know that anytime there's a rehospitalization, there's a higher kind of a mortality and all those markers. And as I said, it's very challenging, and that's kind of confirming that what we are here today, just the heart failure is a challenge, and it's going to be challenged to the patient, to the providers, and of course to the healthcare system.
I just thought of one other thing, just taking a page from what we used to do for COVID, right? Call the physicians when we discharge them. So every now and then, if there is a complex case, we do that. So again, it takes a bit of time, but we give them a heads up and say, this is why we started this patient on an SGLT2 inhibitor. This is why we did this, monitor for this. If you need help, shoot me a text. So there's that level of, so that's something that we're also trying to incorporate now. Yeah.
I do think that, you know, as challenging as Connect Care is in terms of, you know, our time and all the rest of it, there's all these benefits that, like, you know, you talked about that I think that have helped to improve patient care as well. I totally agree.
Sure.
So on behalf of the department, I just want to thank you both for making the trek across the river and for an outstanding grad rounds. Thank you.
Thank you very much.
Thank you.